Now let's discuss these MCQs. A 56 years old diabetic and hypertensive patient presented with sudden drooping of his left eyelid and there is diplopia. So when there is a drooping and diplopia, then it means that it's a third nerve palsy or Horner syndrome. But in Horner syndrome, there will be drooping, there will be anisocoria but not diplopia. Diplopia, the eye will be down and out. Like on examination, there is mild ptosis with exotropia and hypotropia. Pupillary reaction is normal when there is so eye is down and out and ptosis, it is third nerve. If pupil is normal, then it is due to diabetes, and if pupil is involved, then it is due to aneurysm. So answer is B. Now in the second question, a 7 years old child was brought with deviation of the right eye since last 1 year. On examination, bilateral anterior posterior normal. On Hirschberg, there is right esotropia, deviation plus 6 diopter refractive error. When you give glasses, the eye becomes straight. So esotropia, which becomes straight with glasses, that is accommodative esotropia. So that's the answer of the second question. Now in the third question, a young patient with decrease of vision presented. Vision is counting finger both eyes, and with refraction he gets 6 with -3 diopter sphere and -1 cylinder. So when sphere is minus and cylinder is minus, it means compound astigmatism, and the sign is minus, so it is compound myopic astigmatism. Now question number 4, a female child 9 years old presented with swelling of the eye after insect bite. On examination, vision is normal, there is periorbital swelling, tender, red and hot. So all the signs of inflammation are present along with lid swelling, and there is no proptosis. When there is proptosis, then it is orbital cellulitis. When there is no proptosis and lid is edematous, swollen, tender, it is preseptal cellulitis. Now 5th question, a 20 years old healthy young female presented with complaint of photophobia, sensitivity to bright light in her right eye with black discoloration. On torch examination, the right pupil is dilated and non-reactive to light, but when the person sees near, it constricts. So not reactive to light and reactive to accommodation, that is Eddy's tonic pupil. Now 6th question, hypertensive patient presented with sudden painless decrease of vision in the left eye few months ago with no improvement. Now catch is hypertensive patient. On examination, vision is counting finger in the left eye and 6/9 in the right eye. The right eye was normal while left eye fundus showed dirty white disc with blurred margins. You diagnosed it as a case of secondary optic atrophy. So which could be retrobulbar optic neuritis? Well, the age is not given, but hypertension is not related. Then orbital tumor, that is not the right, hereditary, it will present since birth, toxic, there is no history of alcohol. So it is anterior ischemic optic neuropathy because it is associated with hypertension. Now the 7th is a 23 years young female presented with sudden painful decreased vision in her right eye since last few days. Now young female, painful decrease of vision, vision is 660, there is relative afferent pupillary defect and swollen disc. So the best, so it is a case of papillitis or optic neuritis, and the best treatment option in this case would be intravenous steroids followed by oral steroids, the regime of optic neuritis. If you give oral steroids only, it can increase the chances of recurrence. Topical steroids have no role. IV steroids alone are not indicated. Now 65 years old, male patient had left cataract surgery a few months ago with no improvement in visual acuity. On examination, vision was 6.9 in the right eye and 6.60 in the left, bilateral pseudophakia with PCI wells. Now there is a wise ring matlab total PVD with full thickness macular hole. So it's the last stage. When there is a full thickness macular hole with attached partial PVD, it is stage 3, and when there is full thickness PVD with full thickness macular hole, then it is a stage 4. So answer of this question is stage 4. Now 60 years old, male patient presented with gradual painless loss of vision in both eyes on fundi, bilateral tractional retinal detachments. Which of the following is not a cause of this? Tractional retinal detachment can occur in proliferative diabetic retinopathy, retinopathy of prematurity, penetrating trauma, Eales disease, but toxemia of pregnancy is one of the causes of exudative or serous retinal detachment. So the answer of question 9 is A, toxemia of pregnancy. Now 10th question, 70 years old, non-hypertensive, non-diabetic female presented to you, completely decreased vision both eyes. Now 70 years old, very elderly female, 660 vision, bilateral pseudophakia, normal discs, but macula is elevated and there are hemorrhages and exudates along with drusen. Now drusen are in macular degeneration and there are hemorrhages, so it's basically a wet form of age related macular degeneration. It is not hypertensive retinopathy or diabetic maculopathy or Coats disease or CSR. So it's a case of age related macular degeneration. And now let's come to question number 11. Which one of the following pupillary reflexes is used to check for RAPD? Relative afferent pupillary defect is checked by swinging. It is also called swinging flashlight test. So answer is C, swinging light reflex. Now 80 years old hypertensive patient presented with right eye sudden painless loss of vision. On examination, vision was PL in the right eye and 612 in the left eye. Now there was RAPD in the right eye. Fundus was pale edematous. Vision is extensively decreased. Perception of light. And there are no hemorrhages on the fundus. It is a pale white fundus with red spot at the fovea, cherry red spot. So it's a scenario of central retinal artery occlusion. So the answer is A of question 12. Now for 13 and 14, a 61 years old hypertensive diabetic female presented with sudden painless loss of vision in her left eye. Now vision is 660 in the left eye and there are early cataracts in both eyes and right fundus shows mild background diabetic retinopathy, whereas left fundus shows extensive flame-shaped hemorrhages all around with cotton wool spots and cystoid macular edema. Now flame-shaped hemorrhages are notorious in central retinal vein occlusion. So answer of question number 13 is C. Now let's go to the next stem. What will be the first line therapy for the left eye? Now there is a macular edema. So for that you need intravitreal anti-VEGF injection. Now a young male patient presented with painless blurring of vision in both eyes. Vision is 636 which is corrected to 66 with minus 1.50. So vision becomes 66 with minus 1.5. Anterior segment shows right heterochromia, ground glass capies. So whenever there is a heterochromia and ground glass diffuse capies, it's a case of Fuchs uveitis. So it is not a sympathetic ophthalmitis. There is no history of trauma. It is not an angle closure glaucoma, not a chronic anterior or acute anterior uveitis. Now how will you treat this patient? Well, his vision becomes 6.6 with minus 1.5. So you need to observe. But in Fuchs uveitis, you should know that if there was a cataract and his vision was decreased and not improving with the -1.5, then you can go for cataract surgery in such patients, or if the intraocular pressure is increased, you can give anti-glaucoma medications. So here your answer is observation.